We're here in Letchworth Garden City at the Taymount Clinic, and we're really happy with all the questions that you've been putting forward on the Power of Poop group, and we're really eager to answer them, so let's go. So we're here with Glen Taylor, Director of Science of the Taymount Clinic, and we're going to go through all your questions one by one. So here we go with question 1.
Can my condition ever warrant FMT? Can I give you a personal story for this one? I've actually been down this route myself. I suffered a sporting accident that required surgery on a leg, and unfortunately I picked up an infection in that leg injury before everything had sorted itself out. And I went down that same route you have gone. I was going to the bathroom 15, 20 times a day. I saw my cognition go down. I became depressed. There was a whole bunch of symptoms which I expect you're going through at this moment in time. And I recognized that in order to rectify it needed antibiotics, and the antibiotics were actually quite powerful. I underwent the program, and I felt all of the side effects of antibiotics that went with it as well, and it was not a pleasant experience, so my sympathies are with you. But when I get to the end of my treatment with the antibiotics, I had one slight difference. I had already been placing my stool into storage and being processed, so my own microbiota was in the freezer. So the moment that I reached the point where the antibiotics had washed out, I used my own implants. Within 24 hours, I was on the road to recovery. With a couple of days, I was straight back to normal. So after antibiotics, not specifically about Clostridium difficile, but the overuse of antibiotics, powerful ones, is FMT effective? In my particular case, highly effective. And in a number of patients who've come here with what doctors describe as post-antibiotic IBS as a title, we've addressed that, so yes. Well, I can't answer for the methodology employed by this particular doctor because you haven't provided me with any evidence. I do not know what he did, how he did it, how he prepared it, how he applied it. I don't know how many treatments that he carried out. So it's a really, I'm sorry for sort of criticizing this, but I don't know enough about that doctor's own procedures to be able to comment on it. However, I can say that we've not experienced this ourselves. And it may well be that the doctor concerned was treating patients who were already on a pathway for an autoinflammatory disease. We don't know enough to give a specific answer. Our own clinical observations are when patients arrive, over a long or short period of time, we get a resolution, but we don't see, as what's suggested here, a return to or an increase into an autoimmune or autoinflammatory condition. That sounds a very familiar situation for us. You have to remember the Taymount Clinic is not under the constraints of many other countries where it is purely as a treatment protocol involved for Clostridium difficile. The Taymount receives patients with a broader range of presentations. Now, as far as the fat malabsorption is concerned, you've had your gallbladder removed. A little bit of research then you'll find out that without a gallbladder producing large amounts of lipases to break down the fat, you're not going to absorb that very well at all. Supplementation may be needed there. So do some research on your own or talk to a naturopathic doctor to address that particular situation, but it could be supplementation you're going to be needing there to deal with that. But in terms of everything else you've described, one of the things that we face here is patients arrive after having undergone numerous heavyweight treatments with antibiotics. And of course, antibiotics kill bacteria. Not just pathogenic bacteria, but all bacteria can be killed with antibiotics. They just use the same methodology for good and bad. So after a treatment with antibiotics, the Taymount clinic simply restores gut microflora back to normal. So I have to say, in your particular instance, FMT is a highly appropriate treatment. Let me address E. coli. Escherichia coli is one of the most common species found in the human gut, and there are over 100 species within that family group. They're highly beneficial, but equally a number of them are very pathogenic. It's unlikely that you will find anybody without any altogether. I'm not quite sure what methodology they're using to find these, but all our donors have a regular distribution. So we simply restore the regular amounts. Whether you can actually have a response against E. coli, I'm sorry, but it's highly, highly unlikely. In terms of your uveitis, in Europe it's called a retinopathy, and we have had an experience with one patient who had excellent resolution of her retinopathy halfway through the treatment program, and it was just as an incidental comorbidity. She'd come in for major disruption of her gut microflora as a result of overuse of antibiotics and had what you call uveitis. And in this particular case, her birdshot retinopathy was improved, and I think we're waiting for the latest results on that to find out if we have a substantial resolution. So that is something that we have done. If I can refer back to your notes, because there was so much in it, I can understand why, if you were on a course of probiotics, your other microflora improved. That seems to be part and parcel of heavyweight supplementation of probiotics, in that they improve the background, but they don't necessarily add to your native commensal species. For that, we resort to the original species from the human gut, which we've harvested out, the fecal microbiota transplant. So you can see improvements, but you may not see all of the species put back, and supplementation, by our experience, is not going to do that. The addition of missing species through FMT appears to provide the answers that you're looking for. Okay, helminth therapy, a big area all on its own, and Taymount doesn't actually get involved in helminth therapy, although we have friends who are involved in that specifically. I have no experience of utilizing helminth therapy, although I acknowledge that it's an interesting area of study, particularly with autoimmunity. So will Taymount ever provide implants with trichuris? No, that's part of the elimination. It's not our area of research, not our area of expertise, so I'm afraid helminth therapy is not something that we currently are involved with. Okay, thanks for that one. This is a straight science question and has a straight science answer. For decades, we've been storing bacteria for examination purposes, for research purposes. So the methodologies we employ are straightforward scientific storage methods. Bacteria replicate at a certain period of time. Some species are very rapid to grow, split in half, binary fission, and some are very, very slow. Now, the human gut contains bacteria of an entire spectrum of period of replication. When you take energy out of their environment, heat, when you cool them down and make them very, very cold indeed, you slow down the life period of bacteria. So by freezing at -18, a classic sort of domestic freezer, the bacteria will continue to live, but in slow motion, but not slow enough. So their life cycle will continue, and the quick replicators will start to die off. The slow replicators will still be halfway through their life cycle. The more energy you take out, the colder it gets, the longer they last. For example, if you put them in liquid nitrogen at 55 Kelvin, you could probably keep them indefinitely. We keep them at -80 to 84, which takes a huge amount of energy out of them. Sorry, I should have said that in Fahrenheit for you, for the Americans amongst you, but if we stick to the sort of the ISO, the units we use at the moment are centigrade. So if you freeze at -80, -84, you increase all of the bacterial lifespan, although some will continue to die off. So, for example, when we keep them at -84, we would hold on to them for about 2 years. If you warm them up to -40 or -18, you then shorten their lifespan, and that's all there is. So we use the coldest method to store ours, and when they go into the domestic environment, -18 means that rate of dying off increases. So try to use them within 6 months, and try to keep them as cold as you can. Okay, 2 questions, one on PSC. We actually have a patient running through the program having presented with PSC, and we have changed their gut microflora. We're still collecting those results, so I'm not ready to actually release anything on that yet. So I'm sorry I can't be specific about the PSC. On the second part, the use of antibiotics prior to coming in for a treatment. The object of having the bacteria put in is to repopulate the gut with commensal species. And patients who have got dysbiosis have got a very bad balance of their own remaining commensal native species and pathogenic species which are being opportunistic. They've jumped in there because there's no one keeping them out. So there has to be some address to the gut microflora of people coming in for FMT. And we've developed a methodology where we reduce the total pathogenic burden of this legacy dysbiosis when a patient comes in. And we try it really from the most gentle way possible. I'm not a big fan of fighting pathogenicity with antibiotics. I'm a big fan of reducing the gross mass of legacy microflora, including the pathogens, by a multiple methodology of reducing physically how much material is there. And then during FMT, it's a numbers game. It literally is. The incoming new microflora are literally going to outnumber. There's going to be a large balance of beneficial bacteria. And bacteria are very good at regulating themselves once they're in place. So if there are existing pathogens, your new microflora will regulate the amount that they're allowed to grow to. Not necessarily eliminate them, because they still may play an important role in the cascade effect inside the gut. So some pathogens are vital. Even though they're pathogenic, they play a role in the gut. So the idea of killing everything with antibiotics doesn't work well with me. I'd much prefer to reduce, by our methodologies here at the clinic, the amount that the patient starts the treatment with by more physical rather than chemical means. Ted, for me to answer questions about DIY is very difficult because we are just not in control of any of the factors involved here. So I've got to really sidestep this one and say I cannot give advice for safety reasons, in that I simply don't know the conditions at which it's being carried out, what the origins of the material is, what the circumstances to the preparation, the equipment, the understanding of the patients, the experience. None of it is within my power to be able to talk about. So if you don't mind, when it comes to home FMT, the Power of Poop has a very large area of information already on it with people who've carried out their self-implanting. But the Taymount clinic is not a clinic that is able to provide that information. Gosh, Rosa, it's going on all the time. Let me tell you that there are institutes all over the world looking into this, because we now understand the relationship between bacteria and the immune system, and we also understand the relationship between bacteria and genetic expression, vitally important. There are a large number of specialists working on this, so it's all going to come out fairly soon where the reports and studies are being carried out. For example, at St Thomas's Hospital in London, the immunology team is doing a lot of research on the relationship between bacteria and the immune system. And at King's College, world famous hospital in London, King's College Hospital, the head of genetic epidemiology, Professor Tim Spector, who is also the head of the twin study, is doing an enormous amount of work to look at genetic expression, differences in genetic expression, and different diseases. So there's a massive amount worldwide going on currently about the mitochondrial DNA and genetic expression. So yes, there will be. If you do some research, you're probably going to find some now. James, it's currently available. There are an increasing number of labs around the world that offer stool analysis to some degree or other. There are a few of them, I mean American Gut Project, and some within Eastern Europe who spent a large amount of money on this. Would a metagenome analysis as a control before your implant procedures and a post-treatment similar analysis yield you anything that's meaningful? I would offer that it's the patient experience that is actually going to give the answers rather than hard data. Bearing in mind that a comprehensive metagenome analysis by a competent lab runs into many, many thousands just to find out where you are now, so that you can then do a comparison later. It can be done, and for those who can afford to spend that much money, it may yield some interesting results. Whether it changes anything at this stage, I doubt it. When we get the price of metagenome analysis down to a manageable level, when it's cheap enough, then, as I answered in a previous question, it may be possible to characterize and provide donors specific to the characterization. And that could well be an interesting area of research to find out whether it's a relevant one or not. But at this stage, the patient experience appears to be more important than simply knowing where you were and where you are after the treatment. Mena, not nice for a parent to have to report on a child's illness, and I'm sorry that your daughter's not well. This one's a complex question, so I'm going to keep the notes to hand and see if I can just answer these one at a time on there. She had FMT when she was 13 in a clinical study, and we don't know what the study was for, what were the outcomes, what were they looking for, why was the child included in the study, what were the aims here. So it's a bit difficult to put this in context because we don't know where we're starting from. You say that she's now 16 and has Crohn's, but you didn't say she had Crohn's, so I don't know whether the study was about a Crohn's patient. So I'm kind of, at this moment, given the information you've given me, grasping at straws. But what I don't know is how FMT was administered, from what sort of source. Was it a single implant? Was it multiple implants? Were you looking for diversity and density from multiple sources? How was it done? Was it done orally? Was it done rectally? If rectally, was it done with a catheter, or was it done colonoscopically? If it's colonoscopically, as we know, there's good hard now clinical data to show that up to 3.8% of patients undergoing routine examination by colonoscopy get readmitted into ER, an accident emergency situation, within 30 days of undergoing a procedure. So there's lots of unanswered questions here. I don't know what was going on. Was your daughter heading towards a flare after, during the FMT? One thing we do know now, it's a good understanding that with inflammatory diseases, when there is an attack on the epithelial layer, that stimulates a demand for stem cells to replace the damaged cells. So they're made in the bone marrow and they arrive at the scene of the damage, and sadly naive stem cells, because they don't know what they've been told to be yet, naive stem cells are pro-inflammatory. So they raise the inflammatory markers and the inflammatory levels at the point of inflammation just slightly. Bacteria are also pro-inflammatory. If we utilize FMT at the time of a developing flare, it is tantamount to throwing a bucket of gasoline on a fire. So we always back off FMT treatment if there's a suggestion that the patient has got some elevation of their inflammatory markers, be it fecal calprotectin or, okay, you're going to have to help me on this one because I've just blanked on this one, C-reactive protein or C-reactive protein. So I don't know the circumstances here, and it's difficult to answer it in a straightforward way, but your child may have already been on a pathway to inflammation, so it may have just happened anyway. Yet she's back in remission, Remicade, methotrexate, excellent. That's the point where we invite patients to come back in and say, if your markers are now back under control and acceptable levels, we can accept you back in. So we do take care not to add to the problem when a patient is getting close to a flare. Now that she's symptom-free, but it's advisable to try the FMT. It now will be a much more safer period for you to do so, because you want to stop the horrible medications. Now, she's 16 and has Crohn's. Crohn's is an interesting inflammatory bowel condition. It comes in 3 types, and one of the types, and that is the ulcerating type, has been shown to have some kind of response. The 2 other types, stricturing and fistulating, the etiology, the reason why it exists and how it develops, is still largely unknown. And the relationship between bacteria and those 2 developing subtypes of Crohn's are still undergoing some research. So if your daughter has got ulcerating Crohn's, may be an opportunity to replace the gut microflora. I couldn't make any comment if it was fistulating or stricturing, because there simply isn't the evidence there to suggest that at this stage. Well, first of all, you're making the assumption that FMT is a direct treatment for a disease state, a specific disease. And there's no indication anywhere, unless there's been double-blind, placebo-controlled, randomized trials, and a number of them done on a large sample, that will allow us to call it a treatment. At the Taymount Clinic, and we've done something close to 20,000 procedures now, we are here to restore gut flora back to normal and to not treat a specific disease with FMT as though it was a treatment protocol, as though it was a pharmaceutical drug. That's not how it is done, and it's certainly not how we see it. So, to your question, are we collecting data? Yes. We clearly have got a lot of data because we stay in control with our patients and we record what's going on. Have we got some kind of feedback? Yes. It is very rough because every single patient has different comorbidities. It's not like a trial where you go in with very strict guidelines, and patients are eliminated because they don't fit the guidelines, and you're looking specifically to deal with one thing. Here, we're restoring gut microflora in a patient with a disease state or a number of comorbidities. So they're going to respond differently in each and every single case. So have we got an observation so far after what's getting close to 5 years of operating within the area or this space of FMT? We are seeing a 33% fairly rapid response towards a resolution, towards a symptom-free environment. We're seeing 33 over a longer period. Do we know how to differentiate between the two? No. Do we understand the markers yet? They're not becoming apparent enough to make sense to everybody. What about the last 33%? That's the most interesting bunch of all. What happens when people don't respond? And that's why we need to understand, is it a genetic expression? How long will the genetic expression need dealing with if it changes at all in that particular patient? So it's a whole area of research all on its own. How much does all this research cost? Well, each one is something in the region of millions to fully understand. That sort of budget is obviously in the hands of pharmaceutical companies, but this part of, I wouldn't call it experimental, but it's certainly cutting edge, it's new, it's looking at new methodologies. If you're looking for guarantees, if you're looking for absolutes, you have come to the wrong place. You need absolutes, you need to stay with pharmaceutical medicine because that has had a huge amount of money thrown at it. So I can't make any promises. There isn't enough data. It's only just being taken up around the world. For the last few years, there's been precious few of us who have entered into this space. Now the research is increasing. Now academics are getting involved. Now medical establishments are starting to understand and wanting to know what's going on. Now pharmaceutical companies are starting to look at it and saying, is there a component within what they're doing that could be replicated and synthesized to give us something unique that we can perhaps, with luck, get a patent that could make the whole thing worthwhile for us? So we're in a position where we can't make any promises, that we are simply restoring the human gut microflora back to normal because, from all the evidence that we have to date, it appears that once the gut is functioning correctly, a whole load of other bits of the jigsaw of human health seem to be falling into place. Can I say thank you to Tamla and the Power of Poop group for allowing Taymount to have this opportunity to talk about things. We're going to try and make this a regular event, so if you've got questions in the future, over some period of time we'll be back to answer more of your questions. It's a valuable group. You're swapping some really important and valuable data amongst each other, so don't be frightened of the subject, don't be frightened to ask questions, don't be frightened to ask each other. But do your research, and whatever you do, ensure that there's good science behind it. So take care of yourselves, and I hope to talk to you soon. Thank you.